Getting paid for the work we do is a complex process when dealing with this third-party payer system. Now, in order to be appropriately paid, we have to understand, follow, and apply certain payment rules. In this video, I'm going to address a question by Morgan in the Thriving Urology Practice Facebook group. She asked this question less than 12 hours ago. And it's the same perennial question for which there are no fewer than 5 videos that I posted on YouTube and also here in the Thriving Urology Practice Facebook group. And as always, if you have any questions or comments, please feel free to leave them below, or you can ask during this live stream if you wish. So we're going to talk about Modifier 25 today. For those of you who don't know me, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit, and it's all for free. Let's get into it. This question was by Morgan. We are having trouble, she asked, we are having trouble getting an E&M service covered with diagnostic cystoscopy done at the same time, even with a separate diagnosis and appropriate modifier. For example, a cystoscopy is performed for gross hematuria evaluation. Significant BPH was found. Documentation includes separate diagnosis from the procedure, which was gross hematuria. It includes discussion on the disease state, medication management versus surgical intervention, discussion of actual surgery that was planned, and then the carrying out of informed consent process, etc. So her question was, number one, anyone seeing the same difficulties in payment? And number two, how do you bill or navigate lengthy discussions with patients requiring surgery after cystoscopy? Well, this is a very, very common scenario, very common problem, something that I think I do every single day in the office. Is I do a lot of cystoscopies in the office for workup of gross hematuria, for workup of BPH. So I'm going to, as with anything else, unfortunately, I'm going to have to make some assumptions in our discussion. Number one, I'm going to assume we're talking about Medicare as the payer. And number two, we're talking about place of service 11, meaning you are providing the service in the office. So I'm going to answer directly to your question, Morgan. Question number one was, do we have difficulties in getting this paid? No. In my practice, we don't have any problems getting paid because we deal with payers that don't play games like this. And also Medicare should be paying you when you, based on your description, you have two separate diagnoses. First of all, you don't need 2 separate diagnoses when using Modifier 25, but you have 2 separate diagnoses. And if you're dealing with Medicare, Medicare should be adjudicating and paying these claims when you have appropriate documentation like you described. You have separate documentation for the cystoscopy, separate documentation for the discussion, the implementation of the plan, and also the discussion, the consent process that you carried out. All that is documented in the chart. You should be paid when you append Modifier 25 to the E&M service when you perform that E&M service with cystoscopy CPT code 52000. So I'm going to also assume I'm going to think that you are probably not dealing with Medicare, because Medicare, all the Medicare administrative contractors are pretty good at understanding the current appropriate NCCI guidelines when it comes to payment of Modifier 25 related to a CPT. So they should be paying an E&M service with a Modifier 25 appended when you perform cystoscopy in the situation, scenario, and the documentation that you described. They should be paying for it. So I'm going to also have to assume that you're probably talking about a payer that is not Medicare. But I'm assuming that we're talking about Medicare in this case because that documentation is very clear. When you're dealing with private payers, they may differ. So I've said this before. Those of you who have followed me for a while, the insurance companies have a fiduciary responsibility to not the patient, not the physicians or the APPs, not the HR people, not the companies that pay the premiums, but to their stockholders. They have a fiduciary responsibility to make a profit to the stockholders. That is the bottom line. So I euphemistically, figuratively say that the insurance companies deceive, deny, delay, and decline. That's their job from my perspective, right? They want to delay payment, deny payment, because a lot of these claims that are denied are not appealed. Well, heck, that's free money to the insurance companies, right? If they just deny, say, 15, 20% of the claims right off the bat, whether or not you billed it correctly or not, if they simply deny those claims, most of those claims are not going to be reworked and resubmitted. That's easy profit for them. So if you are not going after these claims that are inappropriately denied, number one, you're losing money for work that you already performed. And number two, you're just simply making the insurance companies fatter and richer. So one of the things that you can consider doing is to educate your payer as to the proper coding and the NCCI guidelines. There's no shortage of these guidelines available. You can find multiple YouTube videos that I've done. If you look up John Lynn Modifier 25, you will see a list of no fewer than 5 videos that I've done. Also, if you search Modifier 25 in the Thriving Urology Practice Facebook group, there's a plethora of videos and discussion and posts and comments and responses regarding Modifier 25. So you may have to educate your payer as to the proper coding and the NCCI guidelines so that they can appropriately pay you. And also, number two, definitely do not simply acquiesce, lay down, and do not appeal your claims. You want to appeal until you are appropriately paid, because based on what you described, you did the right thing. The CPT for 52000 includes the preoperative workup, the intraoperative, the performance of the procedure, all the supplies, and also telling the patients what you found, how to recover from the procedure. It does not include the implications of the findings. What are the treatment options? The decision to come up with a particular treatment option, and then discussion regarding the risks and benefits of that treatment decision. That latter part that I described is not included in the CPT, in the perioperative workup of the CPT, for instance, cystoscopy. So all the extra work that you did, that you described, is not part of the CPT and is billable in an appropriate E&M service. Stick to those guidelines. There's plenty of written CMS guidance and CPT guidance regarding the use of Modifier 25. Okay, so you said, how do you navigate this issue? You asked, how do you bill and navigate this lengthy discussion with a patient requiring surgery after cystoscopy regarding resumed TURP, whole lap, suprapubic prostatectomy, whatever it may be? Unfortunately, if the payer is playing games until you can resolve this coding issue and educate your payer so they can appropriately adjudicate the claim, unfortunately, if you want to be paid for that service, you may need to have the patient return to see you again. Now, not necessarily in person, via telemedicine, which is a much more palatable thing to the patient so that he does not need to come back into the office. So you can set him up for a telemedicine visit after the cystoscopy. Telemedicine visit will be for another day, so you can discuss the implications, the treatment options, the risks and benefits of each treatment decision, and then the final decision to undergo a surgery, and also the perioperative course, the informed consent process of that surgery. So all of that discussion can be carried out via telemedicine on another day so that you can be appropriately paid. Now, it is more hassle for the patient, of course, and for you. So there's going to be additional time commitment, more hassle for the patient to set up their telemedicine, which is very simple. I use a very simple, straightforward platform called doxy.me, no financial relationship. If the patient knows how to use a website, has webcam, camera, they can get on telemedicine. But of course, this is also subject to copay, co-insurance, and deductible, and it requires more work for your staff to set up that telemedicine appointment so that the patient can follow up. But if you are doing all that work, and I think it is appropriate for you to be compensated for the work that you performed. It is inappropriate and it's just wrong, criminal for the insurance companies to not pay you for the work that you did. That is clearly under the guidelines. You are following the guidelines appropriately. It sounds like you're doing the documentation correctly. There's no reason why they are denying. So you may want to get your coding staff, talk to the payer, get them on the phone, and maybe educate them on the proper coding, and certainly have all the documentation, the backup, and stuff like that to, number one, either email to the payer so that they can be educated without getting them on the phone, or number two, you have to set up an appeal, third level appeal, so that they can appropriately pay you, not just this time, from here on out. The other thing you can consider doing, which is what I did recently by dropping the largest private payer in Arizona, is that, first of all, they are the biggest headache, they're the worst payer, and if they play games, such as in your case, if they want to play games like that by not appropriately paying you, think about dropping them. Or here's something that you can do: scale back on seeing their patients, they're insured, by seeing the existing patients, but see no more new patients from that particular payer, contract permitting, of course. And if they are not going to significantly impact on your bottom line, because as they have taught us in business school, right? No profit, no mission. Your number one job, and this is euphemistically speaking, your number one job as a urologist, as an APP, is, believe it or not, to run a profitable business, right? Your success, your patient success depends on your success. Your patient success depends on your success. If you do not run a profitable practice, you will not have the privilege to take care of your patients. You will not be able to pay payroll, pay insurance, pay overhead, pay the electricity, pay rent. You won't have the privilege to take care of patients if you're not running a profitable practice. So consider cutting out that payer from your life if you can. That is another one of the options, so that you can concentrate on taking care of the patients who deserve care, right? I'm not saying that the patients who are insured with the other insurance company do not deserve care, but those patients may also be educated, and their HR staff may also be educated that, hey, this particular payer is playing games. You may want to consider other options when it's time to renew your contract with that particular payer. So sometimes reaching out to the HR or human resources staff of the employer of the patient who's typically paying the premiums for that insurance company, that is probably another option for you to pursue. Because these insurance companies, the only thing they know is money. When it hurts them financially, they respond. So those are some of the things that you can consider doing. Let me answer this question. Dr. Shakuri Rod says, it's amazing how many professional coders don't understand these modifiers. Certainly worth learning the rules. I 100% agree. And to that end, if you want to really up your game when it comes to appropriate coding, billing, compliance, I highly, highly, highly recommend that you obtain more education. The American Urologic Association has some coding courses that you can attend, and also the upcoming Urology Advanced Coding and Reimbursement Seminar, UACRS, by the Painters, Mark Painter, Scott Painter, Dr. Ray Painter. These are, I think, probably the gurus when it comes to coding and billing, and I've been very, very honored to be invited as one of their speakers in the upcoming Urology Advanced Coding and Reimbursement Seminar. One will be held in Las Vegas in December, and one will be held in New Orleans in January. Updated 2024 CMS physician payment schedule and new rules and payment rates will be discussed, and how you can navigate that and also optimize your practice operations. All of that and a lot more will be discussed. If you go to prs.com, they will direct you to the link so that you can sign up for these courses. These courses actually come with a guarantee that if you do not recoup or make more than the the cost of the course, you get some sort of a guarantee, you get a refund. And so far, I don't think there are any refunds as far as I'm aware of, because in the past, when I attended as a paying attendee, I certainly go every year or every other year, and I have always gotten so much more in return than the small investment in time. Also, the painters are very empathetic to you, the potential attendees, in that they hold the course on a Friday and a Saturday. So you only miss one day of clinic time. And speaking from personal experience, the knowledge that I've gained to be able to teach this information and also apply that every single day when I see patients has more than paid for the 1 day of lost time in clinic, and also the payment to stay there, to fly there. Besides, I always go to the Vegas course. It's Vegas. Come on. Need I say more? So check out the Vegas course, prsnetwork.com. Papa Romeo Sierra Network.com. I'll put the link in the video description. And also I'll put the link to the one of the YouTube videos where I discuss Modifier 25. Also, I'll put that in the video description. And as always, thank you so much for the privilege of your time. Please take care of yourself and take care of each other. Bye-bye.